I'm Dr. Walid Chalhoub, and I am one of the advanced endoscopists here at MedStar Georgetown University Hospital. Advanced endoscopy is a field in GI that deals with procedures that are not basic endoscopies. Basic endoscopies are upper endoscopies, such as an EGD, which is something that just goes into the esophagus, stomach, and small intestines and deals with just basic GI diseases. And colonoscopies are endoscopies that go into the colon and deal with basic colon diseases. Advanced endoscopy has more advanced procedures, such as ERCPs, EUSs, and endoscopic submucosal dissections. It needs a whole level of extra training. And this extra training helps us go into minimally invasive techniques that deal with bile duct diseases, that deal with pancreatic diseases, that deal with pancreatic duct diseases. And these procedures help patients go into a minimally invasive way of dealing with both malignant and benign diseases. ERCP is a technique, which is an endoscopic, again, technique. We can actually go inside the bile duct and try to deal with diseases of the bile duct itself, that being benign diseases such as stones or strictures, or even malignant diseases such as cancers of the bile duct. And an ERCP has no cutting from the outside of the body. That's why these procedures are very helpful with patients, and they go more with a non-surgical route. And patients like them more in a way where they are minimally invasive versus a more surgical, more invasive technique. I'm not saying that they take over surgery, but they are primarily the first mechanism of dealing with biliary disease, it being benign or malignant initially. Colon cancer is very prevalent, and when somebody has a family history of colon cancer, they have to be very aware that they are at an increased risk of developing it. Other conditions that increase the risk of developing it is if they have genetic disorders that actually put them at that higher risk as well. And those genetic disorders are usually either things that they have known since they were born, or things that they have passed on in their family too. Smoking actually increases their risk as well. Their race increases their risk as well. All these are factors that put patients in certain categories of having increased risk of colon cancer. And that needs to be discussed with a primary care physician, always. Screening for colon cancer is imperative and very, very important. The new guidelines for screening have changed recently, and the age for screening has changed for all races, dropping down the screening age to 45 most recently. It was 50 for everybody, and now we're going with 45. So this is something that I would like all my patients to be very aware of, that they need to start screening earlier. We are seeing a lot of pathology in much younger patients these days, and that's why screening, again, I cannot stress on how much imperative screening for colon cancer is these days. Yes, we do, specifically in patients that are very young. So depending on if somebody's, for example, 55 and they do have a cancer, then probably not. But if in somebody who's 19 and has it, then yes, then there's something obviously very evidently wrong. Or in somebody who's younger than 45, usually, there's something going on that's not usually normal. So those are the patients that we always do refer to genetic counseling. Pancreatic cancer is a very evolving field, and its research is very evolving as well. What was known 5 years ago is very different than what was known 10 years ago, is very different than what was known 2 weeks ago. And it's more of a consensus more than a guideline. And with the most recent consensus, pancreatic cancer screening has changed recently. So the most recent consensus is in patients with a family history of somebody who in their immediate family was less than 50 who had it, and they have high risk as well, high risk predisposition for them to develop it, are now being deemed eligible for screening. There's no really one screening technique to do this. So endoscopic ultrasound, which is something we do here at Georgetown, is a technique for actually screening them, which is also an endoscopic technique. It's just like a regular endoscopy, but the endoscope itself has an ultrasound potential, which is very easy, just to take a look at the pancreas and see if there's any lesions within the pancreas that are possibly cancerous. And we're trying to actually create a registry of these patients who are at high risk for pancreatic cancer development. So these patients have a high risk of developing pancreatic cancer if they are genetically predisposed, number one, or if they have specific lesions in their pancreas at a young age, such as pancreatic cysts as well. When you're at high risk, it depends on age, number one, family history, number two, and what types of lesions in the pancreas you have, number three, going on. And here at Georgetown, we're trying to develop registries where we categorize these patients and try to put them into different categories, really much so that we can follow them and develop more guidelines into screening them. The screening criteria for colon cancer would be age for 45, family history, history of polyps in your family, and then any genetic predisposition in the family as well. These are like the major things that we do look for screening in colon cancer. Not getting screened is just putting yourself at risk, because humans at the end of the day make polyps. And polyps, if left in place long enough, do progress to cancer. So the whole point of colonoscopies saving lives, they do. Because just like we make hair and nails on the outside of our bodies, we make polyps on the inside of our colons. So we need to go in and give our colon that haircut it needs every time on a schedule. Blood thinners are some of the medications that we do advise our patients to stop prior to colonoscopies. Really instantaneously. Once you wake up, I tell you exactly what I found, just because colonoscopies are visual exams. I examine your colon visually. I take a look, I see polyps, I take them out. If I see cancer, I tell you, I think this looks malignant or not. Just because we removed polyps during colonoscopy, it's not like you have a quota in your life that you made these 3 polyps and that's it. Once a polyp maker, always a polyp maker. That's what I tell my patients. And that's why you have to come back. And the time interval for you to come back is catered or tailored to how many and to what size of polyps I took out during your colonoscopy. So let's say I took out one very small polyp, then you come back in 7 to 10 years. If I took out a larger polyp, then you come back in about 3 years. So depending on what size and how many polyps I took out during your colonoscopy is the time that you have to come back. It's what your genetics are composed of is what puts you to that risk and for that risk. So really that's why you have to get these done. MedStar Georgetown University Hospital is one of the pretty much first university hospitals here in the region to establish a fellowship in GI. I think that educating fellows and residents in a program and teaching them keeps a program on its toes and on its cutting edge of excellence and education. And I think that is what puts us, this is one of the things that puts us at a higher bar of being one of the most superior programs, probably, on the East Coast, if not the nation, number one. Number two is our multidisciplinary approach to patients. So it's not just a GI program. It's a GI program that's married to a surgical program, that's married to a radiology program, that's married to an IR program. We all work together for a patient. It's not just a GI person doing a procedure for one patient. So this is what's very nice about it. The MedStar team is not just a GI team. The MedStar team is a GI team and a surgical team, and again, an IR team. And we all come together to make sure that our patient gets exactly what they need.